نغير هاي. Next slide. Sometimes you don't choose the subject chose you. So I was just thinking how to get you involved in this topic, and because we are talking about catheters, balloons, stents, and now we are talking about drugs and diabetes. I guess all of you know this man. He is Andreas Gronzing, who performed the first angioplasty on the LAD in humans successfully in September 1977. And it was a game changer because it started a new era of coronary intervention that we are using now, and we are saving so many lives of patients, especially in patients with acute coronary syndrome. If we look at the projection that in near future, in the next 10 years, we are going to have around 500 million patients with diabetes, and we know that the main killers of diabetic patients are chronic kidney disease, congestive heart failure, and diabetes included, especially when with this triangle of death you see in one patient. And we know that there is a big association between the incidence of myocardial infarction and diabetes and the level of the A1C. And we know that there is a good association also between the level of A1C and the incidence of the microvascular disease. And we know that the incidence of heart failure is doubled in diabetic males, is 5 times incidence in diabetic females, is 10 times more in diabetic young females. And if you look at this slide and you see what heart failure, when it is added to diabetes, does to the patient, it just increases the mortality 10 times more. And if we look at the survival at 5 years of patients with heart failure at stage D, we see that it is at 5 years, the survival is 0. And if we look a little bit upper at the stage C, C1, C2, we can see that the survival of those patients at 5 to 7 years is less than 20%. So if we can find something that is the sodium glucose transporter inhibitors that can reduce the cardiovascular death by 38%, all-cause mortality or death from any cause by 32%, hospitalization for heart failure by 35%, kidney endpoints that includes the end-stage renal failure and renal death by 30%, events in patients with heart failure with and without diabetes by 27%, and cardiovascular events in patients with heart failure, regardless the diabetes status and the level of A1C. Actually, we can call this group of medication a game changer. Unfortunately, the diabetologists and the FDA, they closed their eyes on the approval of anti-diabetic or diabetic medications for 40 years. The only requirement that they were asking for to approve a drug, that to show that this drug just reduces blood sugar and makes the A1C less. Nobody was looking at the safety data. Nobody was looking at to what extent those medications can reduce the incidence of cardiovascular events. And if we look during that period at all the major randomized trials done, we can see in yellow that the incidence of cardiovascular events or disease in patients with diabetes was neutral, nothing positive. The only drug that showed some positive effect in patients with diabetes on cardiovascular events was metformin. But if you look at the number of patients, it is 342. With this number of patients, you fairly can say something positive or to consider it as a major study. And this continued till 2007 when Stephen Nason from Cleveland Clinic published his meta-analysis on rosiglitazone. Rosiglitazone, that was called Avandia. And he showed that there was significant increase of the incidence of heart attacks, myocardial infarction, and heart failure hospitalization on patients who were taking rosiglitazone. And from that time, there was explosion, a volcano of medical trials, including large number of patients, just to prove the safety of antidiabetic medications. And if we summarize all the trials done on gliptins that we use very frequently now in treating our diabetic patients with cardiovascular disease, we can see that they do nothing, just they reduce the blood sugar and the A1C, although we can see if we look at the SAVOR trial, the EXAMINE trial, there was a signal of an increased incidence of heart failure in our patients. The first surprise came out in 2015, when the first trial on empagliflozin, the EMPERIG study, was published. In that study, all the patients were enrolled with proved cardiovascular disease, with MIs, multivessel disease, 10–15% were in heart failure, and the results were surprising. This was the first surprise. If we look at the curves, you could see 38% reduction of cardiovascular death, 32% reduction of mortality or all cause of death, 35% reduction of hospitalization of heart failure, although there was no actual reduction of MI or stroke. So it was the first time when antidiabetic medication given to a patient with proved cardiovascular disease, we could show significant reduction of cardiovascular events. The second surprise came with DECLARE TIMI 58 study done on dapagliflozin. In DECLARE, they included patients, not all of the patients were with cardiovascular events, 60% were at risk, 40% were with cardiovascular events. Again, the trial was positive, and it showed around 17% reduction of cardiovascular death, reduction of mortality, and when they looked inside the trial, compared patients with prior MI, without prior MI, and they compared patients with prior heart failure, with heart failure, and without heart failure, they could find significant reduction of events. This is very interesting slide to show that down the slide, if you look at the patients without heart failure, actually the reduction was minimal, just 12% reduction, relative risk reduction of events. And if you look up those patients with heart failure but with preserved ejection fraction, there is minimal separation of the curve. But if you look in red at patients who were with heart failure and reduced ejection fraction, there was 38% reduction of events. And when they looked at the renal endpoints, it was shown that all the trials done showed significant reduction of the renal endpoints. Let me find the slide. I'm in a break. No, I'm going back. كيف نكبرها بس هاي؟ كيف نكبر؟ كمان. If we look at all the studies done where the renal endpoints were included, EMPERIG, CANVAS, DECLARE, we can see that there was significant reduction. The major surprise on renal endpoints came with the CREDENCE trial. CREDENCE trial, two major issues differentiate this trial from other trials, that they included patients with 99.9% on RAS inhibitors, and they included patients with significant to moderate kidney disease, 30% were with GFR between 60 and 45, and 30% of the patients were with GFR between 45 and even 30, which is significant kidney disease. And if we'll go through all the numbers, all the endpoints, doubling of serum creatinine, renal end-stage disease, renal death, cardiovascular death, hospitalization for heart failure, we will find positive and significant reduction. And the last surprise with those drugs came when dapagliflozin, this with DAPA-HF on dapagliflozin was published this year. In DAPA-HF, they included patients with heart failure, with reduced ejection fraction, but not all the patients were with diabetes. 55% were without diabetes, and 45% of the patients were with diabetes. And if we look at the baseline treatment, we can see that all the patients were actually on the guideline recommended medical therapy, including beta blockers, MRA, ARNI, Entresto, ACE inhibitors, ARBs, and everything. And what was the result of the study? If we look at the cardiovascular death or hospitalization for heart failure and urgent visits to the ER, there was 26% reduction of events. There was 30% reduction of worsening of heart failure. There was a significant reduction of cardiovascular death, and there was significant reduction of cardiovascular death and hospitalization for heart failure. So it is for the first time we can see that we are giving anti-diabetic medication to patients with heart failure without diabetes, and we are getting almost the same results as in patients with diabetes as without diabetes. When they looked inside the result at that, we can see that in patients with diabetes, there was 25% reduction of events, and patients without diabetes, there was even more reduction of events in this group of patients. In the trial, 10 to 12% of the patients who were enrolled were on sacubitril valsartan, and they looked at the effect of added dapagliflozin to those patients, and they found out that there was added significant reduction of events in patients with reduced ejection fraction who were on sacubitril valsartan when dapagliflozin was added to their therapy. If we look in details at the all endpoints happened to those patients with diabetes and without diabetes, as shown in this table, you will see that the reduction of events was almost the same in both groups, and it was regardless the baseline level or the reduction that happened with the A1C of those patients. Of course, everybody will be interested what happened regarding the side effects or the adverse events of adding dapagliflozin in patients with heart failure and reduced ejection fraction, considering that all these patients, they have multiple therapies and diuretics included, and we are worried about volume depletion, hypovolemia, hypoglycemia, and diabetic ketoacidosis, and it was found that there was actually no significant difference between the group with DAPA and the group on placebo. So, trying to explain what is the mechanism of action of DAPA or other sodium glucose transporter inhibitors in those patients, if we'll start to talk about the renal effect, it is much easier. It is considering the tubulo-glomerular feedback in those patients and the restoration of the normal relation between the distal and the proximal tubule, and finishing or ending the hyperfiltration that happened in patients with diabetes. And this actually happens when we add the sodium glucose transporter inhibitors, and the same thing happens when we add the renin-angiotensin receptor blockers or the renin or the ACE inhibitors. When we add the sodium glucose transporter inhibitors, it was shown that with the restoration of the normal feedback between the distal tubule and the glomerulus, this will cause a vasoconstriction of the afferent arteriole, and this will lead to the reduction of the intraglomerular pressure. Same thing happened with RAS inhibitors, but the RAS acts not on the afferent arteriole, but on the distal arteriole, causing vasodilation, and this will lead also to the reduction of the intraglomerular pressure. But all those explanations of weight reduction, blood pressure reduction, increasing the hematocrit or the reduction of the A1C in patients with heart failure on dapagliflozin, or the increasing of ketone bodies, or improving the energy status of the myocytes by increasing the ketones and making the heart consuming less oxygen and making more ATP. This was viable for discussion actually before the DAPA, before dapagliflozin was given to non-diabetic patients. Through diabetes, it's easy to explain so many things, but with non-diabetic patients and heart failure, maybe we need to look for other explanation for the mechanism of action. People goes now for the sodium hydrogen exchanger. We have actually 9 isoforms of this enzyme. The sodium hydrogen exchanger 1 is in the heart, the sodium hydrogen exchanger 3 in the kidney. And it was shown that in the kidney and in the heart, with heart failure and diabetes, there is an increased activity of this proton exchanger. And actually, the main function of this proton exchanger is to maintain the cell volume, the cell pH, by pumping instantly and permanently the proton out of the cells and getting the sodium inside the cell. And it was found that with more activation of sodium hydrogen exchanger, there will be hypernatremia intracellular in patients with diabetes and in patients with heart failure. And with increasing the concentration of sodium inside the cell, this will lead to the increase of the concentration of calcium, and this will affect the concentration of calcium inside the mitochondria, and with that will damage all the energy balance inside the myocyte. So if we can inhibit the sodium hydrogen exchanger with the sodium glucose transporter inhibitors and restore the electrolyte balance between the cytoplasm and the mitochondria, this will get the myocyte to the normal track. This is why actually we can explain all the effects of the medications that are giving positive results in patients with heart failure and renal impairment. We can see that ACE, ARBs, MRA, and the pralazine inhibitors, they actually have some effect on the sodium hydrogen exchanger 1 and 2. We can see that the sodium glucose transporter 2, they can inhibit both in the kidney and in the heart. So, in conclusion, not to make the story long, we can say that the sodium glucose transporter inhibitors prevents heart failure in patients with diabetes type 2 and established cardiovascular disease. Sodium glucose transporter inhibitors prevents worsening of heart failure in patients with type 2 diabetes and heart failure with reduced ejection fraction. Actually, in these studies, patients with preserved ejection fraction were not included, and we know that patients with preserved ejection fraction, they are totally different from patients with reduced ejection fraction, because now I have 3 minutes. I will finish. Yeah. I have 3 minutes. Reduced ejection fraction, they are different from patients with preserved ejection fraction, because patients with reduced ejection fraction, it is neurohormonal disease. It is neurohormonal activation, while in patients with preserved ejection fraction, it's not neurohormonal disease, it's not neurohormonal activation, it is a persistent low-grade inflammation in the vessels and in the heart. Now we can say that dapagliflozin can be added to RAS inhibitors and RNA in patients with reduced ejection fraction with and without diabetes. And we can say that dapagliflozin significantly reduces cardiovascular events in patients with congestive heart failure with and without diabetes. And thank you.